Assalamualaikum everyone and good afternoon. I'm Amna Mohammad Arif and I welcome you all to Australian Concept Infertility Medical Center. As you all know that today we are here for a webinar which shall be presented by one of our most respected and consultant doctor. To begin with, I would like to start our webinar session with the word of Almighty Allah. सर एमर से पूछो कि वॉइस ठीक है, थोड़ा और ऊंचा बोलने की जरूरत तो नहीं है. Thank you so much for staying with us. I would like to give a small introduction about our Institute Australian Concept. We have started this around 22 years ago. As you all are aware of it, that it is one of the largest IVF branch network in Pakistan. We are responsible for first FET baby of Pakistan, that is first frozen embryo transfer. We give complete IVF treatment to patient under one roof, independently, quality assured by Australian scientists on a regular basis. We have the most trained and highest number of gynecologists in IVF techniques and technologies in Pakistan. I would like to commence with our webinar session, and the session will be presented by one of our most respected doctor, Dr. Uzma Imran. She is a consultant obstetrician and gynecologist at the Aga Khan University Hospital for Women, Aziza Hussaini Hospital, and also an assisted reproductive therapist technologist at Australian Concept Infertility Medical Center. Dr. Uzma Imran has completed a medical training from Dow Medical College, Karachi. She did her MCPS in OBS and Gynae from CPSP, then proceeded to UK to take her membership exam from Royal College of OBS and Gynae and completed MRCOG UK in 2002, FRCOG UK in 2014. Dr. Uzma Imran is also an active member of ASPIRE, Asia Pacific Initiative on Reproduction. She is a well-known professional organization in the field of infertility. Dr. Uzma Imran has shown her expertise in laparoscopic surgeries and ultrasound imaging in OBS and Gynae. In many aspects of infertility, including different IVF procedures, Dr. Uzma Imran had been an active figure all across Pakistan. So I would like to welcome Dr. Uzma Imran to please come and proceed with our webinar session.
Okay, Assalamu alaikum, my colleagues. I welcome you all to this webinar today. First of all, I would like to thank Dr. Sajjad and the administration of Australian Concept Infertility Center for giving me this opportunity to speak today. Today we will be discussing a very important and challenging topic, which is the impact of COVID-19 on infertility services and how we can deliver fertility service in this pandemic. So briefly, what is COVID-19? Coronaviruses are a large group of viruses that cause illness, ranging from common cold to more severe illnesses such as Middle East respiratory syndrome and severe acute respiratory syndrome. Lately, a novel coronavirus, that is SARS-CoV-2, is a new strain which we all know that it has spread rapidly and exponentially owing to its rapid community transmission, high virulence, and sustained surface viability. Now, because of its rapid community transmission and high virulence, and we have seen that it has impacted life of everybody on this globe. And our subfertile patients and reproductive healthcare workers are no exception from this. So in wake of this pandemic, On March 17, 2020, ASRM called for stopping the initiation of any new treatment cycles, and this was the document which ASRM has issued. And what they asked for suspension of initiation of all new treatment cycles, including IVFs, IUIs, and including the oocyte retrievals, frozen embryo transfers, as well as non-urgent gamete cryopreservation. They have also recommended cancellation of embryo transfers, whether fresh or frozen, and they have also discouraged doing elective surgeries and non-urgent diagnostic procedures. They have encouraged increased utilization of telehealth also. So we all know that subfertility itself raises a lot of psychological concerns, and in a study it has been found in about 25 to 60% of the infertile patients, they suffer from turmoil, frustration, depression, anxiety, hopelessness, guilt, and feeling of worthlessness in life. And this has been appreciated by ASRM also in its latest update, which was issued in July. And they have acknowledged that there are psychosocial problems in patients as well as staff. They have acknowledged that the patient concerns include cancellation of treatment cycles, fear of running out of time, never achieving pregnancy, and if they are going for treatment, they are afraid that they will get exposed to the infection in the medical offices. The staff concerns include that how to manage the anxieties and the concerns of the patient, and they have the fear of exposing themselves and exposing others to COVID-19. And because they are working in shifts, and some of the staff is quarantined, there is always increased workload, and there are financial uncertainties also. So there was an we know that fertility is a time sensitive issue for some of the patients, especially those patients who have advanced reproductive age, those patients with diminished ovarian reserve, and there are patients who have compelling social pressures like separation, divorce. They are threatened by their husbands and in-laws for separation, divorce. And there are certain patients who have collected finances for the fertility treatment, and they think that they will run out of those funds soon if they don't utilize this money in their for their treatment. So there are financial pressures as well. In an online survey, which was conducted in New York City in an academic fertility practice and published in Fertility and Sterility Journal on April 2020, what they have seen that they looked for the emotional impact of ASRM guidelines on fertility patients during the COVID-19 pandemic. And what they have found is that more than 50% of the patient found it either extremely upsetting or very upsetting. And extremely upsetting, they compared it to, it was like a loss of a baby, loss of a child. So you can imagine the amount of turmoil they have been passing through. They also looked that what percentage of patients agree with ASRM recommendations to suspend future treatment cycles, and you can see large majority of patients don't agree with this initiative. And another aspect which they looked at was how many patients desire to start a new treatment cycle during COVID pandemic. And again, only 24 of the patients were sure that they don't want to start a new cycle. Otherwise, most of the patients want to start a new cycle, even taking the risks of treatment during COVID-19. and about 24% were unsure that whether they should start or not. So, what is needed today is we should consider formulating policies to maximize our ability of care for our patients, yet minimize spread of disease and conserve healthcare resources. So, what I would like you to do is you should categorize your patients in those patients who need urgent care and those patients in whom the treatment can be delayed, and those patients in whom you should not take the risk of treating them and getting them pregnant and exposing them to risks of COVID-19. So for those patients like young patients with a good ovarian reserve who have just tubal problem and in whom you can delay their a little delay of 6 months to 1 year doesn't will not matter. You can give them these tips and keep your patient engaged while they are waiting. You can tell them, and it's not just for women. You can just tell them to get in shape. You can tell them to get in shape and eat right, okay? And they so that they can achieve the desirable BMI. They should continue with the supplements of folic acid and vitamins, avoid smoking or drinking. And this is a golden period to focus on your relationships because in pandemic, most of the husbands are working from home. So they can focus on improvement of their relationships. And this is another opportunity to control their intercurrent problems like diabetes, hypertension, anemia. If they have thyroid dysfunction, you can correct them. And maybe with weight loss and with correction of their comorbids, they might spontaneously get pregnant. So you are also giving them opportunity to do so. Now, those patients who need urgent treatment and in whom a delay of 6 months would be detrimental, 6 months or 1 year would be detrimental. And these are the patients, and you should be able to identify these patients. These are patients of advanced maternal age, those with poor ovarian reserve as indicated by a low AMH, high FSH, or low antral follicle count, and patients with autoimmune systemic diseases who are in remission and they need to go for treatment again. In that, you should make use of those that remission period. We should not ignore the males as well. There may be some husbands who have to travel abroad for a longer duration in near future, and they need semen freezing. Even there might be some males who are taking treatment to improve their semen parameters, and they have semen parameters have improved, and their semen should also be they should also be offered semen freezing, because with time maybe their semen parameters will deteriorate again. Then we have a group of patients with other gynecological problems, like somebody with ovarian cyst accidents, or somebody has a endometriotic cyst which is enlarging, and that is putting pressure on other organs like their ureters or bowel. Or there might be some patients who are having menorrhagia due to polyps or fibroids. So you need to address their problems also. Now, the patients who are poor prognosis, they account for 30 to 50% of the patients seeking ART, and they need an individualized plan of care. And there has been a study which is done by Poseidon Group, and that is a prognostic stratification of vulnerable infertile patients, low prognosis patients. And this study so briefly, what is Poseidon? What is Poseidon criteria? It is a criteria to which tells you the expected response from ovulation induction, And what they have done, they have categorized the patient according to their antral follicle count, their AMH, and their previous response to the any treatment. And they have categorized these patients into 4 groups. And what they say that fertility preservation should be the prior fertility preservation is urgently dealt in patients with oncological patients, patients with systemic autoimmune diseases, and those males in whom semen freezing is indicated. And we have then Poseidon Group 4, which comprises of patients of more than 35 years of age with decreased antral follicle count and decreased AMH, poor ovarian reserve markers. And patient of then comes the patient of group 2, which are patients of more than 35 years of age, but they have good ovarian reserve markers. And then the patients who are younger than 35 years of age and they have poor ovarian markers. So you don't need to delay treatment in these patients. Now there are patients in whom you should defer treatment, and for due to safety reasons, some patients with serious underlying medical conditions at higher risk of severe illness from COVID-19, they should not be allowed to pursue treatment at this time. And these patients are high-risk patients like high-risk patients like patients with diabetes, hypertension, patients who are using immunosuppressants, and this is patients using immunosuppressants, patients with history of lung or liver transplant. And in these patients, you should not start treatment unless you take opinion from their primary physicians. Now coming to the topic that how to provide fertility treatment safely. First of all, you should try to reduce face-to-face interactions like use of video calling, create patient portals. You should encourage injection teach videos so that patient administer their injections at home. And mind it, it has to be done very carefully because injection administration is very important for ovarian stimulation, and your whole treatment is based on that. So you should make sure that patient understands how to do it and patient is intelligent enough to do it. Then you can go for minimal contact drop-off semen sample collection. There you can suggest some home kits for some hormone analysis. And I would say that remote appointments is not for everyone because there are patients who have understanding problem and there are patients who need urgent, who need to start treatment on urgent basis. So it's important to go for a face-to-face call. You should encourage use of PPE by patients and healthcare providers. And the clinic layout should be redesigned following the principles of social distancing. Now here you can change your protocols. You should adapt protocols. You can use a personal gonadotropin dose. Use of GnRH antagonist protocol is encouraged because it is shorter and there is flexibility. If patient, you think that this patient can go into ovarian hyperstimulation syndrome, you can go for GnRH agonist trigger and go for elective freezing of oocytes in embryos. Now, there are some studies which suggest that we can even minimize follicle tracking scans so that so as to minimize the patient visit to the center. And a study was presented in the latest ASRE conference, and what they say that data from follicle tracking scans on day 8, 9, or 10, they can be used safely to make accurate prediction of trigger timing and prediction of risk of over response. So some points for fertility treatment provision by general gynecologists. Of course, you have to follow the same social distancing protocols, and the usage of PPE, encourage that, and redesign. You have to redesign your clinics also to adjust patient spacing. So you can go for face-to-face initial consultation or teleconferencing. It has to be actually you have to go for teleconferencing, which is a better option, where you can take history and request investigations remotely. And when patients visits your clinic, you can examine them and make a plan of treatment for them. It is very important to check previous reports so that you don't repeat the same. I would suggest that you should go for one-step consultation and investigation. The first visit, when your patient visits you, you take a history, and you should give them investigations at once and encourage them to get semen analysis done on the same visit. The baseline investigations which I suggest are CBC, hemoglobin A1C, so that you rule out diabetes. It is fairly common in our population. Vitamin D status, urine analysis, and rubella screening, etc. The hormone analysis which we suggest is FSH, LH, prolactin, thyroid test, ESH, and AMH, which is a very important test these days. You can get the ultrasound done on the same day the patient visits you. It should be a transvaginal scan. And as I've said, that semen analysis should be brought at this on the same visit, so that you can plan the treatment there and then and give them a clear plan of treatment. Like, you should tell them that I'll give you, if they need ovulation induction, I will give you ovulation induction for 3 to 6 months. If we don't get pregnant in spite of making a good egg with a good sperm, then you should go for tubal assessment. We will go for tubal assessment, and then you should suggest them IUI, or if they have a tubal problem, they should go for IVF directly. So don't try, just make a comprehensive plan for them, and you should not be wasting their time, because now they don't have luxury to come to you again and again in this pandemic, and you should also discourage it. So you have to make a comprehensive plan, individualized plan for every patient. Now, what is suggested for fertility center, how they can provide treatment to their patients? First of all, the service providers should keep themselves updated by the latest guideline issued by national and international societies, and they should develop their own protocols, because every country and everywhere this epidemic, the virulence is different, and there are countries in whom this virus has subsided, but there are countries where it's again there is resurgence of this pandemic. So we have to be careful, and we have to make protocols according to our own needs. So because of the changing scenario, rapidly changing scenario, the international societies are continuously updating their recommendations. Like the American Society for Reproductive Medicine has up till now, after the original document, they have up till now produced 6 updates. Likewise, Uh, the ASHRAE, ASRM, and International Fertility Society has produced a combined document in July. Here, I would like to discuss the document prepared by ASHRAE on recommencing ART treatment, because this is a very comprehensive document and I would like to share it with you. Okay. So the first thing what they have recommended is we should counsel prior to starting of treatment. You should counsel your patient in detail with the risks related to COVID-19 disease. Patients should acknowledge that there is increased risk in case they get pregnant during this COVID-19, and you should counsel them how to what measures to take to reduce the risk. There should be an agreement that treatment can be discontinued if patient encounters a high risk situation. Now there is a Triage Questionnaire which they have prepared, and you can download it from their website. Uh, for staff, you should try the how to try the staff. You should put the questionnaire, and you should do it 2 weeks prior to recommencing your treatment. If they are asymptomatic and try negative, they can start work. If they are in gray zone, that they have mild or non-specific symptoms, or they are potentially triage positive, then they should go for the test for SARS-CoV antibodies. You can go for PCR test as well according to prevalence of COVID in your area. If the antibodies or they test positive for the PCR, if it is positive, then they should be referred to occupational health advice and self quarantine. If they are negative, then they can start work. Then there would be staff who are clearly they are symptomatic, or they have history of previous COVID infection recently, and or they are triage positive. Then they should again be referred to occupational health advice and self quarantine. Similarly, for patients, it's becoming really funny. Patient, right? Okay. For patient triage, you should put up a triage again, the triage questionnaire to the couple. Okay? If they are negative, symptomatically they are negative and triage negative, then they can be included in the treatment. That is scenario one. If they are in gray zone, like they have mild symptoms, or they are potentially triage positive, then they should be tested. Again, if they are negative, still you should be open minded with them. And if they are positive, then you should exclude them and refer them to the healthcare professionals. Similarly, at the initial visit, if the couple is test positive, is positive for triage, or they are clearly symptomatic, then also you should refer them for refer them to the relevant healthcare personnel, or they should go for quarantine. This is a triage questionnaire. I will not go into the specific detail, but again, it's a very common thing. You ask for cough, fever, sore throat, and any exposure to a COVID-19 patient. And you can, for patients, you have to ask for other comorbids like diabetes, respiratory disease, chronic renal disease, etc. Now, how to adapt for fertility clinic services? You should reduce unnecessary visits and staff patient contact, and you should encourage use of telemedicine. Sanitation of all areas should be carried on carefully. One second. Social distancing should be maintained. The staff should be provided with protective shields. Again, again, and you should manage appointments so as to reduce the overcrowding. Once again, these are the things which you should follow. Encourage use of PPs and sanitation devices for patients and staff. Redesigning of waiting rooms and working spaces to guarantee appropriate distancing and subdivide staff into mini teams. Now, coming to the treatment cycle. One thing more, how to keep things safe in labs. The labs should follow routine good practice, and they should follow the protocols as given by any international guidelines, and they should follow their own protocols. And the handling of the embryos should be kept minimum. If you don't have time lapse machines, then you should avoid handling of the embryos as little as possible. So when the patients come for treatment, once again, you should put up the triage questionnaire for those patients who were included in the treatment initially, who were triage negative and they were asymptomatic. They should again be asked 2 weeks prior to start of ART treatment. If they are again negative, again at the start of ovarian stimulation, you should put up the questionnaire again. If they are still negative, then you should start the standard procedure and they can go for oocyte retrieval and embryo transfer. Similarly, for those patients who were in the gray zone, you should test for the antibody. You should put up the triage questionnaire and then you should go for antibody testing. Antibody testing, if they are negative, then again at the start of ovarian stimulation, you should check for their antibodies. If it is still negative, then you can go for standard procedure of oocyte retrieval and embryo transfer. These patients who are in gray zone, if they tested positive for the antibodies, you should postpone their treatment. And again, at the start of ovarian stimulation, if initially they were negative, and at the start of ovarian stimulation, they test positive for the antibodies, then if they're positive, you should postpone their treatment. If they're negative, then you can go for the treatment. Similarly, those patients in whom you have postponed the treatment, you should postpone them till they get a certificate from their healthcare authorities that they are clear of the disease, and then you can start the treatment. Now, finally, the code of conduct for staff and patients. What ASHRAE says that all the staff members and patients are instructed to avoid unnecessary exposure, both at work and also in private. So each service should prepare a compulsory instruction for the staff. And attendance at the work will be tied to respecting the signed code of conduct. And activities that are not allowed, they will be clearly detailed. They will be clearly detailed, and they should expose themselves as less as possible. And this code of conduct encourages restricted social life and interactions. Patients should sign regularly that they are well and have respected the code. And also the staff members, they are also required to sign regularly that they are well and have respected the code. And they should inform the center for any violation. If the code of conduct is violated, they should inform the concerned person. So here I would like to conclude my presentation, and in the end I would say that COVID-19 it presents a unique global challenge because of its high infectivity and mortality rates. In the earlier stages, you know that because of the uncertain situation, all the infertility societies, they ask for holding the treatment. But as the COVID-19, the prevalence of COVID-19 is decreasing, they have started recommencing the treatment. But we should adhere to the guidelines because spread of this disease should because of this disease has high mortality, and this disease is still not over. In Pakistan, Alhamdulillah, the figures are decreasing day by day, but we really don't know as the people are getting more relaxed. We don't know with the relaxation, with this relaxation, there might be some resurgence. So we need to follow the protocols. In the end, I would like to say that my salute to all the healthcare workers on the front line of the coronavirus pandemic, and thank you so much. So we have a question from Savera Malik, and she's asking that one of my family member girl of age 21 has menstrual cycle problem. In first 3 days she has only symptoms of blood but not complete flow. On fourth and fifth day flow starts, remains till 12 to 15 days. Kindly tell. uh, this is Savera, what we call as premenstrual spotting. She's having premenstrual spotting, and this could be because of hormonal disturbance. What you need to do is to get her hormone analysis done and also get her pelvic ultrasound done, because sometimes with endometriosis also we encounter such problems. So we need to see where is the problem. Reason for fallopian tube blockage, Huma Sabir has asked her. Reason for fallopian tube blockage could be number one, infections like tuberculosis, chronic pelvic infections. And in endometriosis also we see that the tubes are embedded in adhesions, because endometriosis leads to a lot of intrapelvic adhesions. But most of the times tubes are usually patent. Plus, the reason of tubal blockage could be because of the previous surgery. Surgery can also promote adhesion formation. It can lead to, or any tubal surgery, or any ovarian surgery which led to accidental damage to the tube. So these are the reasons for tubal blockage. And sometimes only the mucus plugs are there. When you repeatedly flush in laparoscopy, they get flushed and tubes get patent. So, which is the primary cause of primary cause of when follicle are can't mature? That is a question from Zainab Burido. Follicles, the maturation of follicle can be arrested because of ovulatory problem. That's why you need to look at the hormones of the patient. If the patient is not having is anovulatory and is not having ovulation, then you should get their hormones test, which I already I have told you that it is FSH, follicle stimulating hormone, LH, thyroid hormone. Thyroid dysfunction also leads to anovulation, and they could be hyperprolactinemia, which can lead to anovulation, and they could be poor ovarian reserve. The other thing is that they could be hypogonadotrophic hypogonadism. So there are a lot of causes, and the most common cause in these times is polycystic ovarian disease, which can lead to anovulation. I also, what is
Patient management used in the organization.
Patient management used in organization. If a patient comes to this center, first they are seen by our coordinators. Our coordinators, they take their basic history and they request for the investigations, which are primarily semen analysis, uh, test for ovulatory dysfunction like hormone analysis. I've already told you, including AMH. I forgot to tell you it's AMH, and they get an ultrasound done for antral follicle count, preferably in the early follicular phase. And the patient then is referred to us, and then we look at their previous records and they again review their history. We look at their investigations, and then we plan for the treatment. Tausif Fatma is asking, can we share it with other people, Tausif Fatma? Okay. She's asking that she has some menstrual problem. She has prolonged cycle, 65 to 70 days. ठीक होता है
तो ठीक होता है, मेरी शादी को 5 years हो गए हैं,
कभी कंसीव नहीं किया. Okay, so she has primary fertility since 5 years and she has prolonged cycles. Tausif Fatma, you have to take that this COVID-19 has proved to be detrimental to a pregnant female more than a non-pregnant person. It doesn't pose any additional risk so far.
What is the role of patient in management that we already discussed?
What is the role of patient in management? Yes, they have to comply, as I have told you, that they have to sign a code of conduct. They have to practice self isolation and social distancing and use of masks, and that is all they need to do. The patients have to follow that. I think social interaction should be avoided. You should encourage them to avoid social interaction as much as possible.
So there's this Kubra Khan. She says if person having again positive test of COVID and it's going 7 to 8 months of fertility, but then what changes face fetus? Any harmful effect, because doctors can treat patients having corona and pregnancy also at the same time.
The thing is that if a pregnant patient is infected with COVID, she has to follow the same protocols as a non-pregnant person. As I have already said, that there is no evidence up till now, there is no evidence that COVID is having any effect on the fetus. They have seen the placenta and they are looking at the amniotic fluid and everything, and still they have not found that this is transmitted. Even they say that these patients can breastfeed, taking all the precautions. They can even breastfeed their babies.
Mohammed, towards the end, is there anything else you can say? I should say maybe
No, it's not related.
That's towards the end.
Okay. Okay, so then I conclude here, and thank you so much. And I really apologize for the technical problems which came across during this presentation. We'll make sure, inshallah, for the next time it is not repeated. Thank you all for attending this webinar, and thank you, Australian Concept, for giving me this opportunity. Thank you so much.
Thank you so much, everyone. Thank you. A bundle of thanks to all of you who had been joining us, who had been staying with us. Thank you so much. I would like to to say a lot of thanks to Dr. Uzma Imran for quality time. This informative session would not have been completed if Dr. Uzma Imran would not have shared this enormous knowledge with all of us. I would thank you all, and I would like to really apologize for all the technical faults, for all those waitings you had been doing. Since whenever there is a mechanical or computer related things are involved, there is always a small chance of issues going on. So, thank you so much for your patience, that is highly appreciated. And inshallah, we'll see you all again sessions in these sort of sessions again. And till then, good luck to all of you. And I would really like to appreciate all the frontline workers, all the frontline doctors who had been working in this pandemic. And it's a big salute from me and my team, an Australian concept, to all of you. Thank you so much for being with us. Thank you. Allah Hafiz.